Hello, everybody. My name is Professor Simon Heller. I'm a diabetes specialist and academic in Sheffield, in the north of England. And it's my great pleasure to be participating in this conversation today with an expert from India, consulting physician who has wide experience in managing people with type 1 diabetes in India. And I'll ask her to introduce herself.
Thanks, Simon. Thanks a million for having me here. I am Dr. Shehla Shaikh. I'm a consultant endocrinologist from Sefi Hospital, Mumbai, saying hi to all of you all out there.
Okay. Well, what I'd like to start off with is introducing this topic. I work in the north of England, where we have relatively few people of the Muslim faith, but we do have a Pakistani population here. And it's always challenging for myself and my colleagues to give advice to people with diabetes. And really, what I'd like to understand from Dr. Sheikh is exactly how she approaches that. But before she does, perhaps she could tell us a little bit about Ramadan itself and why it is so challenging for people with diabetes, type 1 in particular.
Simon, thanks for that question. I think it's a very, very pertinent question because Ramadan, the Islamic calendar follows lunar months. So Ramadan is the 9th month of the Islamic calendar, and it is going to move ahead by 10 days every year. For example, today we are on the 6th day of Ramadan, but next year we will be 10 days ahead because the lunar calendar moves ahead of the English calendar by 10 days every year. So Ramadan falls in different seasons of the year in different countries of the world. Basically, during Ramadan, the Muslim patients all able Muslims are supposed to fast from after adolescence. So even adolescents and subsequently all adults who are healthy, it is absolutely paramount that they fast. It is one of the 5 pillars of Islam. So that is the reason it is compulsory that they fast for maybe 29 or 30 days, depending on the sighting of the moon. During Ramadan, Simon, the people who follow Ramadan will not be eating or drinking or taking anything from the mouth from dawn, that is from sunrise till sunset, and that is the period when they will not be allowed to partake anything. From sunset onwards till dawn the next day, they can eat and drink according to will. There is no problem whatsoever. Now, we need to put across a very, very important concept over here, Simon, which I think it's very important that we tell our audience that Islam permits that if you are sick, if you are ill, if you are traveling, if you are pregnant, you are permitted not to fast. So, this is something which is very important, and also the religion does not mean harm to your body. So, under no situation are you allowed to harm your body. So, fasting, the Quran very categorically says, Simon, that Allah does not will harm to the human body. So, I think this is a very important message we need to also give across, that yes, we understand that all Muslims want to fast, but it is very important that they're able to fast safely. That is of paramount importance. And coming to your second question, Simon, which you asked, why is it so difficult for diabetic patients, especially type 1 patients, to fast? Because we are going to be dealing with prolonged periods of not being able to eat or drink anything, and that can potentially cause hypoglycemia. At the other end of the spectrum, though Ramadan is supposed to be a prototype of intermittent fasting, there is a lot of feasting, Simon. I mean, if you look at some of the Ramadan plates and some of the Ramadan feasts, there's a lot of feasting involved. And this feasting subsequently can also cause significant amount of hyperglycemia. The other factor which contributes to hyperglycemia, Simon, is the sudden reduction of doses because of the fear of hypo. So it's very difficult for you to really judge which direction you're going in at times. And that's the point of time when you may land up with either hyper or hypo. Because you have the risk of hyperglycemia in our type 1 diabetic patients, it always carries along with the risk of diabetic ketoacidosis, which is something which we all would expect and be worried about. And because of the prolonged hours of fasting, you have the additional risk of dehydration and associated thrombosis. These are the four main reasons, Simon, why you would be very worried about your patients fasting during Ramadan.
Okay, thank you. So I've got a couple of questions. So if I understand it, you have a meal just before the fast starts, just before dawn, but then the really big meal is at the end of the fast every evening. And I understand, just taking from a few patients that I have, and also colleagues who are from the Muslim faith, that meal can be really quite large indeed. Is that correct?
It is. Simon, that meal is very calorie dense. It is, I mean, there's a lot of beverages which are very sweetened, which are consumed at that point of time. And those are also social occasions, Simon, because these meals are held in a, I mean, are held in a gathering. So in the gathering, our diabetic patients feel very, very uncomfortable if they are going to be eating something different. And it, because of the social occasion, because of the spiritual occasion, a lot of calorie dense foods are actually eaten at that point of time. And suhoor, the problem is, Simon, most of us are getting up from the sleep, so we are not very keen on having a very heavy meal at that point of time. Most of the sleep patterns are altered, so that is the reason the iftar tends to be the most heavy meal of the day.
Okay, thank you. So I'm going to ask you to provide us with some of the guidance in a minute, but you did say, of course, that people with diabetes, both type 2 and type 1, I suppose, don't have to fast. But in the conversations that I've had, they don't take much notice of me when I say that. They say, actually, I am somebody who wants to be observant, and so please give me the guidance because my firm intention is to fast. And I suppose what would be interesting to me to say, are there any absolute forbidden groups who you say, look, this isn't really a good idea at all? And I'd be also interested in your own experience. How many of the patients that you look after decide to fast?
Simon, before we agreed that okay, our patient should be allowed to fast, we do the pre-Ramadan risk stratification. That is a risk stratification score on the basis of which you can decide whether your patient is having a mild risk of fasting, a moderate risk of fasting, or a high risk of fasting. For example, in the risk stratification score, the highest score is given to patients who are having hypoglycemia unawareness, any kind of hypoglycemia within the last 3 months, and if the patients are, or if the patients are on multiple pre-mixed insulin doses, if the patients do not have a support system which would help them continue fasting, if the patient sugars are not very well controlled. So there are a number of factors which contribute to you finally making the decision as to whether your patient can fast or your patient will not be able to fast. Once you have risk stratified your patient and decided that this patient is in a very high risk category of fasting and this patient ideally should not be allowed to fast, then the conversation would, I mean, we do have a very, very face to face conversation with the patient, explaining all the reasons why the patient should not be fasting, along with a family member if possible. I've always realized if there's a family member involved, if you involve an entire family, it always works out much better for us than if you're talking individually to a patient. But in spite of that, Simon, just like you, we also face situations where my patient will listen to the entire conversation for 30 minutes
Yeah.
and then look at me and say, but I want to fast. I mean, it does happen that way, it's in the real world. And that's when you, as a clinician, do your best to help your patient fast. Because as a clinician, you try to make it as safely as possible. You give the prerequisite education, you monitor them much more closely. You have an entire support system in place to help the patient fast. And then you move it forward and then monitor and take it accordingly, Simon.
Okay, so if we begin to think about the guidance, I suppose in the UK we're very fortunate. It's a high income country, and we have a nationalized health service where we can use the most modern insulins. And because in our type 1 population, the standard approach where they can manage it is to recommend flexible intensive insulin therapy, basal bolus, if you like. We now have the ultra long acting insulins, which we would recommend because, of course, if they work well and if they're reliable and predictable, they can take those and then they just can fast all the time. So, for example, insulin degludec would be an insulin I think that we would probably use as the first choice. And then say to those individuals before each of these meals to take some quick acting insulin, and many of them, of course, can count carbohydrates. And I'd be fascinated to know how you approach the problem in Mumbai.
Simon, we approach the problem very, very individually at this point of time because, we are, of course, a very fortunate country, but we do see people in different strata of society where some patients would be possibly on pre-mixed conventional insulins also. Some patients would be on conventional insulins where they would be not necessarily on premix, but definitely on conventional insulins. We see some patients who are our type 1 diabetic patients routinely. We strictly ask them to be on a basal bolus doses. But in spite of them, because we're a huge country, there would be patients who would be on premixed also and who then come to you for advice during Ramadan. At the other end of the spectrum, we also have patients on insulin pumps who are on the CGMS systems, who are on insulin pumps, who are using who are adjusting their doses, the bolus doses, depending upon their insulin sensitivity indexes, etc., etc. So we are seeing all the entire spectrum at this point of time in our country. Now, coming to a point of time where suppose your patient is on pre-mixed insulin, Simon. Fortunately, if the patient comes to me at least 2 to 3 weeks before Ramadan, it is a little easier because I am then able to speak to the patient. And maybe if the patient is really not affording, also we have resources through which we procure insulin, and we then provide them with long acting insulin and ultra short or short acting insulin and help them fast during Ramadan if the patient is very insistent that they want to fast. But we need the patient to be coming to us at least 2 to 3 weeks prior to Ramadan, because I need that window period to be able to switch the patient to a basal bolus dose and then adjust it subsequently during Ramadan. If my patient has come to me just, and it does happen, Simon, 2 or 3 days prior to Ramadan, it is very, very difficult, to be honest, to adjust. But as I said, I mean, just like your experience, I still face experiences where patients come to me, frankly, just the previous day and say, no, we are going to fast. And then you're doing just whatever best you can.
Right.
In those patients also, we request them to switch to a basal bolus regimen, because on a pre-mixed insulin regimen, Simon, it becomes very, very difficult to manage your type 1 diabetic patients, and then you are really worried about complications. So we try our best to switch them, and because it is just a 1 month period, Simon, most of our patients will be willing to bear that additional cost burden and fast, because it's a question of us being able to tell them, look, you can fast if you do this, because this is then safer for you.
Right. So would you use you'd use an MPH insulin once or twice a day with regular insulin given before each meals, if that's what they were taking before? Is that how it would work?
If the patient was on NPH and regular insulin, the NPH dose I would use it once in the evening,
Right.
but we switch the timing. We switch the timing to iftar timing. For example, iftar at this point in time is 7 p.m. So we ask them to take the NPH at 7 p.m. So because most of the patients sleep a little late, so by the time they've slept, the peak action of the NPH is practically worn off.
Right.
In the morning, initially 2 to 3 days, Simon, we ask them only to take the regular insulin and ask
Right.
them to monitor their sugars midday and in between around 4 p.m. and 7 p.m. so that we have some idea as to how the sugars are behaving, and then individualize and decide after 3 days as to whether we need to add a low dose of NPH if you're having severe hyperglycemia, or what kind of adjustment, or whether we need to further adjust the doses in case of hypoglycemia. So we individually adjust that depending upon the first 3 to 5 days of the fast and how the body is responding.
Okay. So, and do you have, so you have individuals who are using pumps, then I suppose it becomes relatively straightforward to explain to them how they can adjust their basal rates and their boluses to deal with Ramadan itself during those few weeks. And presumably you also do have some access to ultra long acting insulins as well. Would that be correct?
Yes, with the pump, it relatively makes things much more simpler and easier for us, Simon, because over when patients are on the pumps, cost is not an issue at all. Most of these patients are also on continuous glucose monitoring systems, so we have very easy access to their glucose records. We ask them to reduce the rate of the basal insulin 4 to 6 hours, again depending upon their glucose profile, just prior to the time when they're going to be ending their fast. We ask them to, along with the bolus rate, sometimes you may give a single bolus or you may give a staggered bolus depending upon whether this patient is going to have only iftar or is again going to follow it up with another snack post iftar. So it will, the bolus dose would again depend upon what exactly the patient decides to be doing at iftar and post iftar, because the issue, Simon, is that a number that the iftar meal also can vary. For example, some patients may have a light iftar and then may pray and then have a heavy dinner. Some patients will have a very heavy iftar, pray, and then decide what to do for dinner. Some of the the younger generation kids, because as I said, it's a social occasion, do a lot of eating of high calorie food from outside. We have, these places where food is available throughout the night. So there are kids who are, along with the friends going to those places also. So you need to, again, as I said, individualize. I'm unfortunately no one size is going to fit all.
Okay, that's really helpful. So, my final question around the guidance is what do you do about hypoglycemia? As you were been describing this, I was thinking, well, maybe if somebody has a low and a hypoglycemic, they don't have necessarily to eat. They could take a small dose of glucagon. And I just wondered whether that's feasible or actually what you say to them. Look, if you go low, you have to break your fast and are treated appropriately. What advice do you give them for people who do?
I mean, this thought has been, is being sort of bandied a lot nowadays. Whether we should tell them to take glucagon, to be very honest, but I personally feel that if your sugar is going low, it is potentially catastrophic. It can be very, very harmful to your body, and I'm very, very clear in my mind that fasting means no harm to your body. So any sugar which is going low, please break your fast. We give very, very categorical information that you need to break your fast if your sugars are going low. Any sugar less than 70, please break your fast. Any sugar between 70 to 90, may repeat your sugars again after 15 minutes. But any sugar which is in that area, we tell them please break your fast, Simon. So,
Okay,
yes, and we do not have any data as to what would happen, if we give them glucagon and then try to understand. So, theoretically, yes, that sounds very nice, but I am very clear that fasting does not mean harm. I will not be able to give this kind of message. I tell them, please break your fast.
okay, good. So I take that. So my smart aleck idea is a bad thing to do,
No,
and we
no,
should
no.
give up
This
for the
was,
day.
as I said, this is an idea which is being bandied increasingly, and actually, we need more data. But I would be very, very scared of, telling my patient, don't break your fast and take glucagon, to be honest.
No, it's good. It's a good advice. So I'm just going to summarize as I understand it. But before I do, could you tell our audience if there are online guidance? I'm sure there is. What, in your opinion, is the sort of best online guidance that we could be directed towards?
At this point of time, Simon, the best online guidance is in the IDF DAR guidelines. We have an entire IDF DAR website which does give you a lot of information, including information regarding the Ramadan nutrition plate, including information regarding activity, regarding pre Ramadan education, what we need to educate our patients regarding pre Ramadan, when do we break our fast, how do we monitor, when do we monitor. So I think that's a very, very good website to go to.
Okay, that's really helpful, and we'll make sure that the uh, your people are directed to that at the end of the broadcast. So I just want to summarize, and you can correct me if I've missed anything important. So the secret, of course, is education and a discussion and listening to your patients, which of course is the essence of good diabetes care anyway. You will risk stratify your patients, and clearly if they have hypoglycemia unawareness, perhaps if they're pregnant, other conditions, then you would very strongly advise them not to fast. And you point out that in the Muslim faith that is perfectly allowable, but of course, as we've discussed, there are many who want to be observant and will still insist on fasting nevertheless. Education is key. You really need to see them some weeks before Ramadan starts. And what you want to do is to go to a basal bolus, and usually you're successful in almost everybody persuading that, together with increased frequency of blood glucose monitoring or continuous glucose monitoring where it can be afforded and provided. And you'll use both MPH insulin once a day as the basal insulin, but if, again, patients have access, you'd use more modern ultra-long preparations. And hypoglycemia is a must treat. You're not going to mess around with glucagon. You're going to give people advice in the typical way to take oral carbohydrates, because, as you say, it could be potentially catastrophic, particularly in social occasions. And those are the essence, that's the essence of good advice. Have I missed anything that you'd really want to put into that before we finish?
I couldn't have put it better, Simon. That was an excellent summary.
Okay, Shehla, I want to thank you for really good advice. I've learned a lot during your discussion, and I will quickly write it down when this broadcast is finished. But I want to thank you for giving such great advice to our audience, and I hope they find it useful.
Thank you. Thanks a million, Simon. Thank you very much.